Good afternoon, everybody. Thank you for tuning in to Grand Rounds this afternoon. We got a great CPC case conference today. I'm excited. Hopefully, we'll learn a couple of things. I'm not going to waste much time. We have a lot to discuss and a lot of information to get through. So I'll go ahead and introduce our first speaker, Dr. Alex Commanday. He's an exceptional PGY2 internal medicine resident at Emory. He is an Atlanta native, but attended Vanderbilt for his undergrad studies before obtaining his medical degree at Baylor College of Medicine. He aspires to complete an infectious disease fellowship after his training and will be presenting today's case. Alex?
Thank you, Chris. We'll get started here with this case. I'm Alex, a second year, like he said. This is a case of a patient that we saw back in September at Grady Memorial Hospital. So we'll just go ahead and get started with the HPI here. Chief complaint that she can't see. So this is Mrs. B. She's 61, African American, history of insulin-dependent diabetes and hypertension. She had normal vision up until about 2 weeks ago, normal health until that time as well. She noticed that her right eyelid started to droop and she was having some pain over her right temple. This minimally progressed up until about 5 days before admission when she noticed her vision just completely started to darken with, she described as like a veil coming over her eyes. This additionally progressed until the morning of admission when she noticed a complete blackout of her right eye and very minimal vision of her left eye, prompting her to come to the emergency room. She actually dressed inside out on the way there. She incidentally noted some worsening incontinence with laughing and coughing. In terms of review of systems, she didn't have any headaches, any weakness, double vision, any eye complaints specifically, and then no constitutional symptoms as well. Other review of systems was generally negative. She does have some stable chronic kind of lower extremity neuropathy that hasn't changed. Continuing with her histories, medical history, as we mentioned, the diabetes, hypertension, no pertinent surgical history, allergies, family history with diabetes, no autoimmune conditions or cancers, social history, no substance abuse. And then in terms of her medication, she's on a pretty good diabetes regimen with insulin and other medications for blood pressure and hyperlipidemia and for neuropathy as well. No changes to that medication regimen. Moving on to her physical exam, she was a little bit hypertensive and tachycardic, but otherwise afebrile, breathing and saturating well. She generally appeared well and comfortable. On each ENT, she had some mild tenderness over her right temple. Her eye exam, her pupils had already been dilated by the time we got to her, but her extraocular movements were intact, had some right eye ptosis, and then in terms of her visual acuity, the right eye could only see light or motion, and left eye could only count fingers about a foot away. We'll get to the dilated fundus exam in a minute. The rest of her exam was relatively unremarkable, some end expiratory wheezes and respiratory exam, but cardiovascular, abdominal exam, extremity exam, normal. Her neuro exam, really no focal deficits, outside of kind of what we mentioned before with her eyes, and then a skin exam was normal. I included this is the ophthalmology exam. They'd already gotten to her, like I said, before we had, and this was copied directly out of their note. I won't go too much into it, just to say that this was ultimately consistent with some bilateral proliferative diabetic retinopathy, but really nothing to explain her severe vision loss. Moving on to kind of the initial laboratory values that we got. So here's a BMP and a CMP. Metabolic panel, relatively unremarkable, and a CBC showing some leukocytosis, some slight anemia. The remainder of the metabolic panel, really only remarkable for slightly elevated alkaline phosphatase. We did get a urinalysis showing some leukocyte esterase, white blood cells, and some bacteria. An A1C of 9.3, and then elevated ESR and CRP, as you can see there. And then a anemia panel as included. And so I'm going to go through this initial ED hospital course because I think it's very crucial to understanding this case and how we thought about it initially. So she comes in, she gets the non-contrast CT scan with no abnormality, also gets an X-ray and an EKG, also normal, and a COVID that I should say is normal or negative. And before we get to see her, ophthalmology and neurology had already been consulted. And as I mentioned, the ophthalmologic exam and neurologic exam did not point to anything focal that would explain her profound vision loss. And so given the elevated inflammatory markers, vision loss, and then that pain over the right temple, we felt that giant cell arteritis or temporal arteritis was something we couldn't miss. We were also thinking about vascular abnormalities like a dissection, a clot, a stroke. So what we were thinking. So we knew we needed more imaging, but in the meantime, we actually opted to empirically start treating with really high dose steroids, so 1 gram of methylpred. We ordered the CTA and CTV, and then also in the meantime started ceftriaxone for urinary tract infection. So I'm going to go into some of the imaging and the order that we got them. So the first is a CT scan, head and neck. This is very small print, but basically no acute vascular abnormality, though it did show 2 important findings that we're going to look into further. One was this bulky bilateral adenopathy they couldn't visualize too well, and the other was some nonspecific soft tissue fullness in her orbits bilaterally. So first we got a dedicated CT chest to look at the adenopathy, and again it shows and confirms the mediastinal and hilar lymphadenopathy, but nothing too prominent in the actual lung tissue itself. And then we got an MRI brain and orbits, which confirmed that soft tissue abnormality bilaterally. The brain, globe, nerve, muscle, glands, and that MRI were all normal. All right, moving on, the rest of her course. So for the initial concern for GCA and then later this concern for a more infiltrative process, we'd already called rheumatology. And they were concerned for some upper extremity nodules that weren't initially appreciated on exam. And so dermatology was also consulted at this time. For that, elevated alkaline phosphatase, and I didn't mention before, but on the CT chest, concerned for some portal adenopathy, we did get a dedicated ultrasound and CT of the abdomen pelvis, which kind of confirmed that adenopathy in the abdomen there without too many other notable changes or abnormalities. Eventually, a duplex ultrasound of her temporal arteries was obtained, and it was negative. Her vision had started improving minimally, but it was at this time we did plan for an orbital biopsy in the operating room. And it's at this point that I'll turn it over to our discussants. Thank you.
Thanks, Alex. I failed to introduce myself. I'm Chris Masad. I'm one of the Emory internal medicine chiefs for the year. I'm the site chief at Emory University Hospital. And it's my pleasure to introduce Dr. Dan Hunt. He's a professor with the Department of Medicine. He obtained his medical degree at Vanderbilt, where he also completed his internal medicine with his 3rd year at Baylor. He practiced in private practice for a while before he was recruited as a clinician educator by Baylor College of Medicine, where he received over 35 major teaching awards. He was recruited in 2005 by the Massachusetts General Hospital to develop and lead the inpatient clinician educator service for the Department of Medicine, and eventually became the chief of the hospital medicine unit. He joined us at Emory in 2015, where he now serves as the director of the Division of Hospital Medicine and continues to serve on the inpatient wards and participate in a variety of medical educational activities. Dr. Hunt, I'll turn it over to you.
Chris, thank you so much. Great opportunity. And Alex, that was a terrific presentation. I have to say, Chris was really good about keeping information from me in a way of just limiting the information that we get to deal with here. And Chris, I don't know if you have the chat box up where folks can type in their thoughts about this case. It'd be kind of fun. It's your opportunity as an audience where you can type in a diagnosis, and if you get it right, you will be legendary in the Department of Medicine. Now, I probably will be legendary for not getting it right, but that's okay. So let's go forward here. You know, when I deal with a CPC type case, I think about that case in 2 different ways. Thinking fast, thinking slow. And I love this book by Kahneman describing those processes. And so we think quickly about our impression of the case, And then we back up and say, okay, with slow thinking, what do I come to? Do I agree with my rapid response to this case? And as I'm reading a CPC in the New England Journal, I'm often writing in the margins of what I think this might be, and then working through the case. So I'm doing the fast think first, and then trying to go on with the discussant of, am I on the mark? So, Chris, we've had a few seconds. Any creative thoughts? A thyroid panel has been requested. Okay, we can put that on the wish list. All right, let's see. My thoughts, giant cell arteritis. The team apparently thought that was a possibility at the start of this case. Reasonable? Maybe. I thought maybe this is lymphoma. I don't know much about lymphoma involving the orbits, but maybe it's lymphoma. Maybe it's sarcoid. Bulky lymphadenopathy in the chest? Sarcoid comes to mind. Maybe it's a metastatic malignancy. Don't know much about that either. And as you do a CPC like this, you quickly realize that you're going to have to read a ton. And so I had the privilege, and Chris, thank you again for this, of reading a lot to come to what I think the diagnosis is here. Oh, this popped into my head. I don't know why, mostly because I don't know anything about it. So I'm hoping Dr. Mendoza can teach us about that, although I don't think that's the diagnosis. So multicentric Castleman's disease. It's sort of legendary for CPCs. It gets into CPCs far more frequently than it's probably should because of its rarity. Okay, well, let's go forward. When I do a slow think, I build a problem list. And so here's the problem list I came up with, and Alex will check us on this to see if we covered the things that the team was thinking about. And I try to prioritize this as well. So acute bilateral visual loss, it's severe. We have to move quickly if we're going to salvage vision at this point. And so totally agree with the team. Decided we're going to give a big dose of steroids because we're not really sure what this is, but we're hoping it's going to respond. But then we've got those abnormal soft tissue densities on the MRI. And here I'm going to have to give props to Chris again. He told me that the radiology report actually listed some diagnoses, and in those diagnoses was the correct diagnosis, but he was really good about eliminating those diagnoses from the report he shared with me. So it would have been a lot easier, I suspect. Okay, bilateral hilar adenopathy, mediastinal lymphadenopathy with extensive perilymphatic nodularity. Retroperitoneal and portal hepatic lymphadenopathy, CT of the abdomen. This was said to be nonspecific. Elevated ESR and CRP, and I'm going to come back to that toward the end of my discussion because it troubled me a fair amount. Mild normocytic anemia, increased alkaphos, not real increased, but it's increased. Leukocytosis, pretty nonspecific. Pyuria, hematuria. Diabetes, insulin treated, hypertension, obesity, right eye drooping, although it's not noted on all the exams that Chris shared with me. I'm not sure what that means. And the reduced hip flexor strength and falls. All right, let's get into that first list. Maybe this is my whole list. We'll see. Giant cell arteritis, what argues for? Visual loss. I'm not used to seeing sort of the gradual visual loss over a period of time. And we may ask our experts how likely that is with giant cell arteritis. Temporal tenderness, that was intriguing. Elevated ESR and CRP, fairly nonspecific, but there's a fairly limited differential for that degree of elevation. Mild anemia, certainly consistent. However, no symptoms to suggest polymyalgia rheumatica. It took me a little bit away from giant cell arteritis. There was no jaw claudication. Maybe there was some headache, but not real impressive. There were normal vessels in the fundus exam. I would have expected with visual loss and giant cell arteritis to see clear evidence of ischemia. The duplex ultrasound. It's interesting in a systematic review, and you'll notice there are going to be some references that appear on the slides. In a systematic review, the sensitivity of this particular study is 55 to 100%. That's a pretty wide range, probably dependent on operator expertise. But maybe that's good enough to set aside giant cell arteritis. However, I think the thing that does set it aside is the extensive adenopathy, which I would not expect with GCA. So let's cross that one out. And I'm studying the audience here to try to figure out if somebody's really smiling big, I've made a misstep, but we'll keep going. All right, lymphoma. Let's think about what's for it. Well, lymphoma does constitute 6 to 8% of orbital tumors. That's about the right percentage for a CPC. Typically, there's no pain. MRI, this seemed to match with what we heard in Alex's description of the radiographic findings. Once again, and it's also described that it's more common in the superior orbit, which was described in the detailed radiology report. However, bilateral involvement is unusual. In a small case series, only 1 of 19 cases were bilateral involvement. It's usually secondary foci of systemic non-Hodgkin's lymphoma. And so we didn't have that diagnosis going in. There's also inferior orbit involvement in our particular patient that seems less consistent. And there are limited systemic symptoms, which I would have expected with fairly extensive lymphoma. So I'm going to say it's probably not lymphoma. And now you will notice I'm going to skip over a diagnosis for a second. Let's talk about metastatic malignancies. 1 to 13% of orbital tumors are metastatic. It can be the initial sign of cancer. Breast cancer would be the most common malignancy associated with orbital tumors. However, 80% are unilateral, and this was bilateral involvement. The patient has no history of malignancy. There's extensive lymphadenopathy, but no obvious primary. I guess it's still possible, but it seems unlikely. And there's no weight loss in a patient who has extensive involvement. All right, we got to deal with this multicentric Castleman's disease. I'm not sure where it came from in my thought process, but it's up there, so we got to deal with it. And here's a really nice summary of what we would expect with multicentric Castleman's disease. And you'll notice that in this systematic review, inflammatory symptoms were common. It's an interesting review because they do some statistical analysis to say, well, we didn't get reports on these in each of the case reports, so what is the minimum possible prevalence? But it bothers me for this particular patient that we don't see a lot of these things. And we don't see the hematologic findings that we would have expected with multicentric Castleman's disease. So I think I'll probably set that aside. However, here's a quote. Castleman's disease is a rare lymphoproliferative process found in either a focal or multicentric localization. Most of the cases are mediastinal or abdominal. There have been 11 cases of Castleman's involving the central nervous system, but only 1 prior to this particular case report involved the orbit. Now, a little cautionary tale for those of you who have the privilege of doing a CPC. It is not unusual for that case to actually represent the 3rd or 4th reported in the literature. So maybe it's possible. I don't think so. Let's go back to sarcoid. Ocular involvement, 25 to 50% of patients. I think of it more with uveitis. And this was not uveitis. This is some sort of mass or soft tissue density in the orbit itself. So the orbit actually is involved in about 10% of patients. So it's still possible here. It may mimic thyroid eye disease. And so that chat box suggestion about thyroid function, yeah, we probably should check it, although I'm going to have a hard time tying that to the extensive lymphadenopathy in the chest. It may mimic idiopathic orbital inflammation. Chris and Alex, would you put up a case of idiopathic something? Maybe. Now, I found this table really interesting from an ophthalmologic standpoint with a lot of great terms here. of mutton fat keratotic precipitates. Snowballs. We didn't hear about any of that in the ophthalmology report, so I'm going to assume that we didn't find ophthalmologic findings that would be consistent with sarcoidosis. I may get corrected on that by Dr. Mendoza, but that's okay. All right, staying with sarcoid for just a second. Here's a table that gives us a sense of what the systemic involvement, the organ involvement would be. We certainly have some lung involvement based on the radiology here. And gee, I'm not sure I heard about those skin lesions before getting up here. So maybe that's something useful. Lymph node involvement, we certainly have that. Eye involvement, but again, uveitis would be what I would expect. A nice quote, "The diagnosis of sarcoidosis is never secure." That makes me feel much more comfortable, but it's made arbitrarily when the statistical likelihood of an alternative diagnosis becomes too small to warrant further investigation. A number of diseases can affect the thorax in a manner similar to sarcoidosis. Well, look at that. I hadn't thought of that. Systemic IgG4 related sclerosing disease. Maybe we better put that on the list over here and look at those imaging findings. They seem consistent. Let's try to dispense with this idiopathic orbital inflammation diagnosis. And here we go back and think about IgG4 related orbital disease, and here are some diagnostic criteria. And then we think about patients who had been diagnosed with this disorder and how many of those patients, about a quarter in this series, actually were re-diagnosed with IgG4. Same thing with something that seems a little nebulous as well, orbital benign lymphoid hyperplasia. Also a significant number of patients were re-diagnosed on looking back at the pathology. Okay, let's go back to the problem list. We got to go back to the sort of slow think approach here. Acute bilateral visual loss, and then I've sort of dimmed out a number of the other things that I don't think particularly are helpful in thinking about this case. But this becomes the big issue. And now let's build a wish list. I'd kind of like to see an HIV, just because I'd like to see an HIV, although I don't think this fits particularly well for this case. Maybe we should check a serum angiotensin converting enzyme level. I think maybe we should visit radiology. Chris, are we going to be allowed to visit radiology? We will be. Outstanding. So bilateral, extraconal, postseptal, abnormal soft tissue on MRI. And I sort of transposed that and said bilateral orbital masses. And I started Googling. There's something called an iWiki. And it had a really nice list. And actually at the top of that list was IgG4 related sclerosing disease. Then there's some things I actually put crossed out because it didn't seem to fit very well for any of these other things. And then metastasis and lymphoma we've sort of dealt with. So IgG4 disease, diagnostic criteria for ophthalmologic disease, imaging findings, and we're going to look at those. Histopathologic examination, we're going to have to get tissue, and Alex was kind enough to tell us we're going to get tissue at some point in the very near future. This is somewhat, for a long time with IgG4, it was thought that all patients would have elevated IgG4 levels, but that's clearly not the case. However, if it were substantially elevated, it would move our probability upward for this particular diagnosis. So the wish list expanded just a little bit. Serum IgG4 level, I'd like to see it. Let me go back for just a second and make sure we haven't missed anything else that we should consider. So granulomatosis with polyangiitis. As I recall, an ANCA was actually negative for this patient. And it doesn't really fit very well. It doesn't fit for a vasculitis. There's much more lymph node involvement here. Sjogren's, we didn't get a lot of good history there. Thyroid disease came up in the chat. I've sort of discarded it because of the lymphadenopathy in the chest and because of the imaging findings in the eyes. Lymphoma, we said, nah, it doesn't seem likely. Infection, I would have expected that the patient would have significant fever or systemic symptoms and did not. Metastatic disease, we have omitted. Trauma, I'm going to assume that Alex didn't withhold some type of trauma. It's been known to happen in a CPC. And this Erdheim-Chester disease, I have to confess, I didn't even do a lot of reading on that one. So if it turns out to be that, Dr. Mendoza, I'm going to be educated. Okay, a nice series from Zach Wallace, Vikram Deshpande, and John Stone, who are at the MGH. And this is a really nice series looking at orbital manifestations, a lot of lacrimal gland involvement. Didn't hear about that on the imaging, but did hear a lot about bilateral involvement and then a lot of other systemic involvement here. This is a summary, and bilateral disease, 70 to 75%, and orbital fat or deeper involvement, 30 to 40%. And here was an interesting picture from a case report within this reference. That looks like a droopy eyelid to me. Alex, would you agree? Yeah. This is a young patient diagnosed with IgG4. And so that ptosis may not exactly be ptosis. I think we probably would call it more a droopy eyelid. Okay, IgG4 disease. And you're going to see here sarcoidosis is beginning to fade in terms of what I think the likely disease process is. IgG4 is advancing. And here's a summary of systemic involvement with IgG4. And it actually takes me back to my practice experience where I had a young patient with fibrotic pancreatitis that I could not figure out. And now in retrospect, I'm almost sure that's what the disease process was. And I had a young patient with aortitis that I could not figure out. And I'm fairly confident now that was the problem. And several patients with retroperitoneal fibrosis. And this is obviously giving you a little bit more information about how old I am, because this disease was not described until the past 20 years or so. This is a kind of a nice summary of looking at IgG4 levels, pathologic findings of plasma cells, and then the relative frequency of organ involvement with IgG4. I just thought it was kind of a cool way to display information. We're not going to read this, but it's actually a really impressive paper that Zach Wallace is the primary author on this paper that brought together 86 experts from around the world to try to come up with criteria for diagnosis of IgG4. And these are the exclusion criteria that you would say, if this is present, then this patient is not likely to have IgG4. Again, we're not going to read through this, but I've read through it in detail and didn't find any exclusion criteria for our particular patient. The paper goes on to describe the actual scales used to develop the probability of IgG4. And again, we won't read through the detail here, but the major point that comes back from this is we're really going to need help from pathology, because most of the points will be garnered from that examination. Okay, so I'm thinking this might be IgG4 related disease, but I'm troubled by the elevated ESR and CRP. We're going to visit radiology. I've reorganized this a little bit, and let's get a biopsy. And I went to the literature trying to see, is elevated ESR and CRP prevalent in patients with IgG4? And this was a nice summary that suggests, but the levels aren't quite to the degree we've seen in our patient. So I'm still a little bit troubled by that. So my diagnosis, as we walk to radiology to see the imaging and ask some pointed questions of the radiologist, is I think this is IgG4 related disease. Chris?
Thank you, Dr. Hunt. That was fantastic. At this point, we are going to turn it to our colleagues in radiology to kind of help us maybe narrow differential or change it. And I'm going to turn it to Dr. John O'Keefe. He's an assistant professor with the Department of Radiology. He received his medical degree at Georgetown before completing his residency at Emory, where he also completed his fellowship in neuroradiology. He primarily practices at Grady. And at this point, we are going to turn it to Dr. O'Keefe, who will share his screen and review some of the imaging with us as a radiology consult.
Okay, so we were talking about the orbits earlier. So when we do MRI of the orbits, we're usually looking for either IH or optic neuritis or some sort of intraorbital disease. So in this case, you can see the optic nerve looks normal. This is a post-contrast T1 fat sat. It's normal enhancement of the extraocular muscles and of the lacrimal gland. But as we go anteriorly, we see this abnormal enhancing soft tissue that's kind of inseparable from the right lacrimal gland in the superior extraconal space. And then in the inferior extraconal space of the left orbit, we have some enhancing soft tissue this kind of blends in with that inferior rectus muscle. So in this patient, with these kind of enhancing soft tissue mass-like lesions bilaterally, our leading diagnosis would be, as discussed earlier, IgG4 or something like sarcoid, or even potentially lymphoma. But we can also tell that there's no optic neuritis. The optic nerves look normal. The optic chiasm and optic tracts look normal. And then, as mentioned earlier, on the chest, we can see there's just diffuse mediastinal adenopathy, hilar adenopathy, and then even enlarged retroperitoneal lymph nodes. And they mentioned those perilymphatic nodules. So again, all these findings would make me think sarcoid or potentially IgG4. Lymphoma is also possible. I'd probably say a little less likely. But yeah, those were the pertinent findings. Yeah, do you guys have any specific questions about the imaging beyond that?
Dr. Hunt says he's pretty happy with the information we got. Thank you, Dr. O'Keefe.
Sure.
I just want to bring up a couple of things in the chat box. It looks like we've got some people early on before the discussion. Dr. Ray said she agrees with IgG4 disease. We got a couple for sarcoid. Over at Grady, the residents think it's sarcoid, ocular sarcoid. Dr. Armstrong thinks it's sarcoid. We got Dr. Stevens. This is pretty early on in the case, was thinking mantle cell lymphoma, paraneoplastic optic neuritis, cat scratch, Waldenstrom, macroglobulinemia. There was one direct message that was asking about the pathogenesis of vision loss in IgG4 disease and wondering whether it was a compressive optic neuropathy that should or should not be seen on the retinal exam, which I thought was a good question. I think at this point, Dr. Hunt is pretty satisfied, but I agree. I think we're all in agreement that we need some tissue. And at this point, I'm going to bring up Dr. P. Mendoza. She's currently a PGY6 neuropathology fellow at Emory, where she also completed her combined anatomic pathology and clinical pathology residency. She obtained her medical degree from the University of the East in Quezon City in the Philippines. She completed an ophthalmology residency at St. Luke's Medical Center in Philippines before coming to the U.S. to complete an ophthalmologic pathology fellowship at Massachusetts Eye and Ear Infirmary at Harvard, before obtaining a second fellowship in ophthalmic oncology and pathology at Emory. I think she's aptly suited to discuss the ocular biopsy that was obtained. I think we'll share our screen here again. Let's see. And I'll leave this quote here for, all right, Pia.
Thank you, Chris, for that very kind introduction. And thank you to everyone for inviting me to be here today. This is a really interesting, fascinating case. Thank you, Dr. Hunt, for presenting that really great presentation. Thank you, Alex, as well. Great presentation. So let's go into it. biopsy of the left orbit was performed on this patient, and it showed non-necrotizing or non-caseating granulomas. So this is orbital tissue. This is fibroadipose tissue. This white, or the cells with the clear spaces, is adipose tissue, and this is fibrous tissue. And within that fibroadipose tissue, you have this aggregate of cells, which is a granuloma. So the middle part of this aggregate is composed of epithelioid histiocytes and giant cells. So histiocytes are tissue macrophages, and we use the term epithelioid to mean that they morphologically resemble epithelial cells. They have a lot of pink cytoplasm, so the center of this granuloma appears pink. And they are cohesive. They cluster together or stick together, so you can't really tell the cell borders from each other. And you can't really appreciate much of the giant cells here, but there's another little granuloma over here on the side, which does have multinucleate giant cells. I'll show you a higher magnification picture of that in a minute. And around this center of epithelioid histiocytes is a rim of lymphocytes. So these are lymphocytes. They're round and blue with small nuclei and not a lot of cytoplasm. This is a pretty good or very classic, I would say, appearance of a granuloma. For the differentials that Dr. Hunt had brought up, so IgG4 disease, we do get a lot of questions about IgG4 disease in the orbit. I think that was a very good differential to think about. For the pathologist perspective, if we're thinking of IgG4 disease, we would expect a lot of plasma cells. So plasma cells have eccentric nuclei that's off to the side, and they have like a pink rim next to the nucleus. And if you have a lot of them, then that's when we would suspect IgG4 disease. And then we do immunohistochemical stains for IgG and IgG4, and then we get a ratio. And as Dr. Hunt had presented earlier, we would look for a ratio of greater than or equal to 40% IgG4 positive plasma cells to make a diagnosis of IgG4 disease, or to look for 50 IgG4 positive plasma cells in 10 high power fields. So I don't really see a lot of plasma cells here. So I wouldn't really be thinking of IgG4 disease. And, you know, the fact that these are well-formed granulomas really makes me think more of sarcoidosis, especially it's non-necrotizing, which we know is classically associated with sarcoid. And then this is just a higher magnification of these multinucleate giant cells. So there are different kinds of giant cells. We have a Langhans type giant cell. The nuclei are arranged in a horseshoe shape. And this one is a foreign body type giant cell where the nuclei are just haphazardly arranged. Because another differential when we see granulomatous inflammation like this is the foreign body. So that's something we do need to rule out. And this is a naked granuloma. So the one I showed earlier had that rim of lymphocytes around the center of histiocytes. This one doesn't really have the rim of lymphocytes. It does have lymphocytes just scattered around in the periphery, but not really forming a nice rim like that first one. And again, naked granulomas are also, they're not specific for sarcoidosis, but they are known to be associated with sarcoidosis. So our histopathologic diagnosis was granulomatous inflammation. I'll add on here that it's non-necrotizing. We do want to rule out infectious causes of granulomas. So we did a stain, a Gomori methenamine silver or GMS stain for fungi, which was negative, an acid-fast bacilli AFV stain, which was also negative. So we're ruling out like two important groups of things that could cause granulomatous disease. And just general stuff about granulomas, it's a type of chronic inflammation. Plasma cells are included in chronic inflammation as well. Lymphocytes, histiocytes, and plasma cells. But this is an organized, or it's a special form of chronic inflammation where you have these histiocytes organizing themselves into discrete nodules. And as I mentioned earlier, we use the term epithelioid histiocytes to describe these. And these are believed to be due to activation of these macrophages. And they attain that epithelioid appearance, and they secrete a lot of different things, including ACE, which was mentioned by Dr. Hunt as well. You know, we wanted to look at the ACE levels. And this is an attempt of the immune system to wall off substances that it perceives as foreign. So this formation of like containing a foreign substance is why these granulomas form. And this picture is a picture of a necrotizing granuloma, just to contrast with what we had. The center is just very pink. It doesn't have the nuclei, not like in this granuloma over here. So necrosis, the first thing to go when cells die or cells become necrotic is the nucleus. So they lose the nucleus and it's just a cytoplasm that's left, and the cytoplasm is color pink or eosinophilic. So it's just all this pink stuff with some cellular debris mixed in. The presence of necrosis is usually more associated with infectious causes, and we do use the term kind of interchangeably, necrotic or caseating granulomas. Caseating just means cheese-like, literally. The gross appearance has that cheese-like appearance. Although you can have necrosis in sarcoidosis, although the necrosis would be very minimal and not expansive or extensive normally. So our differential, from the pathology perspective, seeing this granuloma, this inflammation is a foreign body. Infectious causes, TB would be higher in our differential, although TB would typically be necrotic versus this one is non-necrotic, so that makes it less likely. Other atypical mycobacteria, fungal infections, so we did our stains and those were negative. Syphilis is also another thing that would present with a lot of plasma cells, but you'd like want to have a history and some other clinical findings to think about syphilis. Autoimmune disease, Dr. Hunt had brought up some of these Wegener's or granulomatosis with polyangiitis, Churg-Strauss. So we didn't see any evidence of vasculitis on this case. So we're thinking less likely of these entities. Something neoplastic lymphoma was on your differential. That will be a sheet of lymphocytes and not this mix of different cells. So we're not really thinking about that. And then finally, sarcoidosis. So again, just to summarize the histologic findings in this case that favor sarcoid, non-necrotizing granulomas, Langhans type giant cells, naked granulomas. We ruled out infectious causes. We didn't see any foreign body. So we did polarize the tissue and we did not find anything. And just other histologic findings that are not in this case, but we do see in sarcoid are asteroid bodies, these stellate intracytoplasmic inclusions in giant cells. Schaumann bodies, which start as calcium oxalate crystals, and then they, with time, they become calcified and form these concentric lamellated structures. Hamazaki-Wesenberg bodies are these little brown pigmented structures that you can find typically in lymph nodes, and they can be mistaken for fungal organisms or yeast, so it's important to know that these can happen in sarcoid. And then fibrosis. So as time goes by, the granulomas in sarcoid can become fibrotic. They start in the periphery, and then eventually they can just, the whole granuloma can just become fibrotic. And we sometimes use the term burnt out sarcoid when we see a lot of this fibrosis. So, yeah.
Thank you, Dr. Mendoza. So I think at this point, we're all in agreement that the diagnosis is actually most consistent with sarcoid. To Dr. Hunt's credit, we actually specifically withheld what was a markedly elevated serum ACE level and a very bland serum IgG4 level, which I think somebody commented on that getting an SPEP would be helpful. But at this point, I want to invite Dr. Friyoy Ayeli. She's an assistant professor and expert on sarcoidosis and received her medical degree from Addis Ababa University in Ethiopia, where she also completed her internal medicine residency and worked as an internist for 3 years. She then completed her internship and residency in internal medicine at Atlanta Medical Center and completed her rheumatology fellowship at Emory, where she has since helped establish the Emory Sarcoidosis Clinic.
Thank you very much for the nice introduction and for inviting me to speak. So sarcoidosis is a systemic inflammatory disorder of unknown etiology, which predominantly affects the lungs, but it can affect any organ. It is characterized by the formation of non-caseating granulomas. It is more common in African Americans and in Scandinavian countries, in Caucasians of Scandinavian descent. It has the lowest incidence in Asians. It can be seen in men and women, but it's slightly more common in women. The peak incidence is at a much younger age in men. It's between the ages of 30 and 50, and it's at a later age in women. The annual incidence in African Americans is 18 to 71 per 100,000 population. It's much less common in Caucasians. There are differences in the clinical presentation in Caucasians and in African Americans. In Caucasians of Scandinavian descent, it presents with acute sarcoidosis, with Löfgren's syndrome, which has good prognosis. Erythema nodosum also tends to be more common in Caucasians. It's rare in African Americans. In general, African Americans have more severe disease. They tend to have more extensive skin disease, more ocular disease, more uveitis, and severe lung disease and extrapulmonary manifestations in general. The etiology is not known. It's not even known for sure if it's an autoimmune disease, but it's thought that some type of environmental trigger, either some environmental antigen, like a particulate matter or infectious agent, in genetically predisposed individuals triggers an inflammatory response. There is dysregulated immune reaction to the antigen, and that's what is thought to cause the inflammatory process. There are different chemicals that have been shown to cause a sarcoid-like illness, like beryllium. Infectious agents, many different infectious agents have been studied, bacteria, commonly mycobacteria and propionibacteria. Even bacterial DNA fragments have been found in the granuloma of patients who have sarcoidosis, but there is no evidence that infectious agents cause it. There were patients with sarcoid-like illness after 9/11, after exposure to debris after 9/11. There are many genes that predispose to sarcoidosis, and there are some genetic genes that are associated with a less risk of sarcoidosis. The most common one, which is associated with increased risk in both African Americans and Caucasians, is HLA-DR beta-1 gene. There are non-HLA genes also that predispose to sarcoidosis. HLA-DR beta-1 O301 is associated with Löfgren's in Scandinavian patients. So briefly go over the pathogenesis. So environmental triggers in a patient who is genetically predisposed will cause activation of the innate immune system, activation of macrophages and dendritic cells, which then activates the adaptive immune system and initiate a T cell response, which is predominantly T helper 1 and T helper 17, and then cytokines are released like interferon gamma and TNF alpha, which cause differentiation of macrophages into epithelioid cells. So normally this T helper 1 response is inhibited by regulatory T cells, but since there is impaired, like abnormal immune response, the T cell response, the T cell regulatory response is impaired and the inflammation just continues to propagate. There are no diagnostic criteria, no universal criteria, and sarcoidosis is diagnosed based on clinical and radiological features, histology showing non-caseating granulomas, and more importantly, ruling out other causes of granulomatous inflammation. Granulomas are not pathognomonic of sarcoidosis. Actually, the most important task in evaluating a patient with possible sarcoidosis is ruling out all the other possibilities which have been discussed, like infection, like exposure to chemicals, malignancy, and things like that. Sometimes you may not need to do a biopsy if a patient presents with typical Löfgren's, and if the patient doesn't have any risk factors for infection, like mycobacterial infections or fungal infections, you may not need to do any biopsy if the patient has a classic presentation with Löfgren's or this syndrome, which we will discuss later, Hilford's syndrome. And same patients who have asymptomatic, who have bilateral hiral adenopathy and no history suggesting infection or malignancy, you can be certain about the diagnosis of sarcoidosis. You don't necessarily have to do biopsy. ACE level, we always get it, but it's very insensitive and non-specific. It can be elevated in other conditions, including infection and malignancy, but it's elevated in up to 2/3 of patients. And if it's elevated, you may use it to monitor disease activity. If it's normal, it doesn't rule out sarcoidosis. So these are the diagnosis tests that all patients should get: chest X-ray, CBC, liver and kidney function tests, serum calcium, because there is hypercalcemia is one of the manifestations, PFTs and DLCO even in patients with who don't have pulmonary symptoms, EKG in all patients to screen for cardiac sarcoidosis, because patients can be asymptomatic and they can present with arrhythmias and sudden cardiac death for the first time. So we should do EKG for every patient. Ophthalmologic evaluation is also should be done for every patient with sarcoidosis, because the most common ophthalmologic manifestation is uveitis, and some patients may be asymptomatic, so you always have to screen them. Tuberculin skin test or other like T-spot and quantiferon to rule out infection, to rule out tuberculosis. And then depending on the patient's presentation, you may get high resolution CT scan. If you have a patient who has an abnormal chest X-ray, you want to know more about their disease, so you should get a CT scan to get more details about the extent of pulmonary involvement. Or some patients may have normal chest X-ray. If you have a high suspicion for sarcoidosis and the X-ray is normal, you should get a high resolution CT scan. And all the other tests listed that you see, Holter monitor, echocardiogram, right heart catheterization if you suspect pulmonary hypertension, CSF analysis, and bronchoscopy with biopsy in select cases. Half of the patients who have sarcoidosis are diagnosed incidentally on imaging done for other reasons. Most patients who have symptoms present between the ages of 20 and 60, patients can have constitutional symptoms. 10 to 15% present with Löfgren's syndrome. Erythema nodosum and Löfgren's is more common in Caucasians, rare in African Americans. This slide summarizes the different clinical organ involvements. Lungs the pulmonary involvement is the most common, which occurs in 90 to 95% of patients. Then the other organs commonly involved are skin, eyes, liver. Asymptomatic elevation of liver enzymes is very common. Elevated alkaline phosphatase suggests infiltration of the liver with granulomas. Nervous system and heart involvements are rare, but they have a high mortality. Pulmonary sarcoidosis is the most common presentation, as we discussed. Patients can present with all sorts of pulmonary symptoms. On chest X-ray, there's a staging of sarcoidosis based on chest X-ray. Usually this classification has limited prognostic implications. So in the interest of time, I would go over to the ophthalmic manifestations. I would like to say a few words about cardiac sarcoidosis. It occurs in 5% of patients, has high mortality. We should screen patients with EKG. You can see different types of arrhythmias, conduction abnormalities. TTE or echocardiogram should be done in select cases. It's used to monitor disease activity. Skin involvement is seen in 25 to 35% of patients. Patients can present with different types of skin manifestations: papules, macules, plaques, nodules. The most common one is maculopapular lesions. Lupus pernio is the most characteristic skin manifestation. Erythema nodosum is non-specific. If you don't biopsy erythema nodosum because you only see non-specific septic paniculitis, you don't see granulomas in the biopsies of erythema nodosum. Lupus pernio is violaceous, lumpy skin lesion, which can be associated with destructive bone lesions. It has a poor prognosis. It's associated with chronic disease, and extrapulmonary involvement is more common in African Americans. You can see infiltration of scars and tattoos in sarcoidosis, so you should examine tattoos in the patient with sarcoidosis. So the eyes are involved in 25 to 80% of patients. The most common presentation is uveitis. Sarcoidosis can cause anterior, posterior, and panuveitis. All patients should be screened for uveitis. Sarcoidosis can also involve, the eyes outside of uveitis. It can cause scleral plaques, can cause corneal and conjunctival nodules, optic neuropathy, and also the adnexa can be involved bilateral, lacrimal gland infiltration is the most common extraocular presentation. So patients can present with dry eyes, dry mouth, they can present with proptosis, they can present with droopy eyes like this patient. You need to rule out IgG4 related disease, you need to rule out granulomatous polyangiitis, Sjogren's, malignancy. Sarcoidosis can also infiltrate the extraocular muscles, and it can also cause soft tissue masses inside the orbit. Sometimes it can also destroy the orbital floor. The mass can extend into the orbital floor and destroy the orbital floor. Hilford syndrome is a triad of uveitis, fever, and facial palsy. If you have this presentation, you don't need biopsy. Sarcoidosis can affect different organs, GI manifestation. Most common one is symptomatic elevation of liver enzymes. Liver cirrhosis is rare. It can present with fever of unknown origin. It can present with arthritis, symmetric arthritis, chronic arthritis looking like rheumatoid arthritis, or acute arthritis with Löfgren's. So I will just go over to the treatment. There are no evidence-based guidelines treating sarcoidosis. Not all patients with sarcoidosis need treatment. It's only a third of patients who need treatment. For example, patients who have asymptomatic bilateral lymph node enlargement with no extrapulmonary manifestations, they don't need treatment. Patients with erythema nodosum, if they don't have any other manifestations, they don't need chronic, long-term immunosuppressive therapy. Patients who have asymptomatic elevation of liver enzymes with normal liver function, they don't need treatment. So we need to identify which patients need treatment. And this is just a list of patients, a list of indications for treatment, like progressive lung disease, neurologic disease, ocular disease, hypercalcemia, disfiguring skin lesions, arthritis that's not responding to NSAIDs. We use NSAIDs for arthritis and Löfgren's. Colchicine and dapsone are used to treat erythema nodosum. Glucocorticoids are the first-line immunosuppressive agents. There's more experience with glucocorticoids than other steroid-sparing medications. Some patients just need treatments with steroids, and they go into remission, and they may not require long-term steroid-sparing immunosuppressive therapy. But when in patients who have refractory disease, or patients who cannot be tapered with prednisone, or who develop a relapse of disease when steroids are tapered, need disease-modifying agents. And the most common DMARD that's used is methotrexate for both pulmonary and extrapulmonary disease. In patients who don't respond to methotrexate or who can't tolerate methotrexate, the other common disease-modifying agents that are used are Imuran and mycophenolate. TNF inhibitors are used in severe disease that's refractory to above medications. You can use hydroxychloroquine for skin disease, for arthritis, osseous disease, and hypercalcemia. Actually, there is more evidence of use of hydroxychloroquine than the other DMARDs. Rituximab and cyclophosphamide are used for major organ involvement like neurosarcoidosis that's refractory to other agents, but there are no randomized trials. This is it.
Just want to say thank you. I think I asked the impossible of Dr. Ayali, which was to go over an incredibly complex disease in about 15 minutes. I thought she did a wonderful job. I want to say thank you to Drs. Commanday, Hunt, Dr. O'Keefe in our radiology department over at Grady, Dr. Mendoza, and Dr. Ayali for joining us for our CPC today. I think I learned a lot today, and I think I will speak for the crowd and the virtual audience as well. And I'm imagining a virtual round of applause for our audience today. Thank you, guys.